So good evening, everyone. We are live now. We can go ahead.
Good evening. Warm welcome to the 33rd webinar of the Pediatric Orthopaedic Society of India. Before I introduce the faculty, I would like to introduce the topic. The topic is growth modulation or a guided growth. That's become a wonderful tool in our management of the limb discrepancy and the growth angular deformity. And today we are going to discuss various controversies, various practical problems related to growth modulation. We are really lucky to have very eminent experts on the subject. We have Professor Ignacio Sanpera from Spain. Then we have Berne Moller-Madsen from Denmark. The inventor and the innovators of the 8-plate, Peter Stevens, is also with us. And we have Dr Nakhda and Dr Padman. They are our own members and they are going to be sharing their views. If you have any question, you can ask your question and on 98230-63989. Let me give a brief introduction about our experts. The Professor Ignacio Sanpera is an orthopedic surgeon practicing in Spain. He had his basic orthopedic training from South Africa. After that, he did a pediatric fellowship from the Great Ormond Street Hospital in UK. Then after that, he started his practice and currently he's a head of the pediatric orthopedic department at University Hospital, Barcelona, Spain. His major area of interest is growth modulation and various pathologies affecting the growth plate. And his work on recovery of the growth plate once the implants are removed is really a very interesting topic. We are not going to go into that today, but we are going to touch it briefly. He has 32 publications and 14 book chapters on this topic. The second expert is from Denmark. He is attached to University Hospital of Aarhus, Denmark, and he is the director of Danish Pediatric Orthopedic Research Group. He was ex-president of European Pediatric Orthopedic Society. Peter Stevens, most of us know him at POSI because he had been to Ahmedabad in 2013 POSICon, and he had his basic training from University of Utah. Then he did his fellowship from Royal Children's Hospital, Melbourne. And after that, he's practicing in Salt Lake City since 1980. As I told, like he's an innovator or the inventor of the 8-plate, and he has published many papers on various use of 8-plate for flexion deformity, for valgus deformity, for ankle deformity. And we are really lucky to have his presence with us for his opinion. Then we have Dr Nakhda. I know that he does not need any introduction. He practices in Mumbai and is attached to Saifi Hospital and Jupiter Hospital. And the most important thing is he's a webmaster of our POSI. And he's also the coordinator for the today's program. So he's an orthopedic surgeon, but equally good technical person also. The Dr Padman has did his undergraduate and postgraduate studies from Pondicherry. After that, he did his fellowship from Sheffield Children's Hospital. At present, he is attached to Rainbow Children's Hospital, Fortis Hospital, and Manipal Hospital in Delhi. Before we proceed, I would like to tell you about the format of this webinar. This webinar is not a one-way talk. It's not a lecture like most of our webinars are, but the format is very different. The Professor Ignacio is going to, first of all, put a case. These cases are going to be very simple day-to-day cases which we see in our practice. And after that, he's going to ask one question. And then we will ask this question to our experts. And once we have their opinion, after that, Ignacio will tell us about what is the literature, the current literature about that particular question. So this is going to be an evidence-based discussion. If you have any question, you can WhatsApp your question to Sandeep on this number. Before I hand over to Ignacio for the talk or for the session, I just request you to enroll for the POSICon 2021, which is going to be a virtual meeting this year. and you can register at www.posi.in. And I just would like to remind you that the last date for submission of papers and the abstract is 1st of December. So please hurry, register yourself for the conference and also send your papers. Brief information about the next webinar. In this 33 webinars, we discuss a lot about the techniques, about the technology, about the tools. But this webinar is going to be very different, which is on the 10th of December. And it is going to discuss about the doctors, because burnout is one of the major problems which we face, and how we can prevent and how we can avoid that burnout problem in our career. For that, again, we are fortunate to have our expert faculty from USA, and we will share more information about that. So with that, I hand over to Professor Ignacio for his presentation and the further discussion.
Professor Ignacio, please share your screen and we can start. Please unmute yourself, Professor.
Thank you very much for the invitation. After this nice introduction, I'm very pleased to be talking for POSI. Well, the first thing, it has been already explained how the system works. So I will present some cases and then we will go from the questions to the panel. The very first question is a very easy question. We have some problem, it's not working. Okay, so it's a boy, age 13. He's complaining of pain in both knees. He has mild genovalgum. The parents are very concerned, and that is his long leg films. He was treated with 3 medial staples on staples in his medial side of the femur. And the question to the panel is this treatment nowadays acceptable? So
okay, so with that, I ask Taral first. You are in Mumbai and you see patients from various parts of the country. Now, do you still use staples or you have migrated to something else?
So when I was a resident, I saw some of the staples in some of the old X-rays. I've seen staples done by Dr. K.T. Dolakia. He was the legendary, very senior orthopedic surgeon, but I've seen some staples. Some came out, some were in, some were broken. And then I didn't see any staples done by anyone else after that. So probably it meant that, it was popular once upon a time and then people gave it because of the higher complication rate. In fact, we wanted to do a study comparing staples to the 8 plates. And to my surprise, the staples were just not available, for us to be used. So I believe that in today's date, there are very few indications or no indications for staples for correction. One more thing I just want to point out from the X-rays is the way we take, sort of long leg X-rays for genovalgum. And what happens is it's very common for an X-ray technician to get both the legs together to take an X-ray of genovalgums, and really that doesn't show the mechanical axis very well. Has been, you can see in the X-ray over here. So now our instruction to the radiology technician is keep 6-inch distance or 8-inch distance between the feet when you take a long leg film for genovalgum, because the visual appearance of genovalgum is not well noticed when the feet get closer when they take X-rays. Yeah,
so you don't prefer staples nowadays, right? No, Manoj, what is your take on that?
I don't think there is any indication to use staples right now. It's been proven, there is enough evidence out there that there are lot of technical issues with staples. They back out, they have failure, and the correction is quite unpredictable. So you need multiple staples. So with the current implants that are available to do, if you want to do angular correction or correction of leg length discrepancy, I don't think in the current age there is any role for staples. That would be my take. The only instances that I've seen in the last several years is staples which have failed, but that may be, not due to, any specific reason as such, and have taken them out and done an osteotomy because they were done, the indications were wrong. But even otherwise, I wouldn't, personally, I don't have any kind of, I wouldn't recommend it. I have not used them in my practice.
Okay, so it's like a 2 by 0. Peter, I'm sure that everyone probably knows your answer. So yeah, Peter, what do you think?
Yes, I agree. The disadvantages make it unattractive, and I no longer use them. But I did meet Dr. Blount in 1981 when he was honored by the Pediatric Orthopedic Society of North America for his pioneering work. And at that time, in our country, stapling had lost some of its appeal. And I explained that I like stapling and I was using it, and he was excited and wrote me a very nice letter. So I did it for 25 years, realizing that bending is okay, but unpredictable. Breakage and migration are not okay. So I decided we need an implant that would bend, that would typically not break or migrate, and switched.
Okay, so like we probably have a one-side answer that staples are completely outdated. Yes, Professor Ignacio, what is your literature review on this?
Okay, so you can see one of the problems of the staples when they were removed, they break down. So, and it was left with some pieces of the staple. But if we look at the literature critically, there is 2 papers that we reviewed from an experimental point of view. One is looking to the difference between different methods of correcting angular deformity, and another is a similar model in porcine model. When we look at the rabbit model and doing the epiphysiodesis, what we did was we compared staples with 8-plate model, and we studied the physis at different levels, either close or far away from the device. And what we saw on the histological point of view is that although at 1 week there is difference between the staples and 8 plates, and the 8-plate, it's compressed, but it keeps well the structure. The staples are completely disorganized. But when we go to 4 weeks, the changes histologically nearby the device are hardly recognizable. You cannot differentiate what is a staple, that what is an 8-plate. But what you can see is when you look far away from the device, there is difference in the sense that there is much more severe changes in the group of the staples than the group of the 8-plate. So the 8-plate far away is better preserved than with the staples. By 6 weeks, it's totally impossible to differentiate between staples and 8-plates. The histological changes are identical nearby or far away from the physis. If we look at the angulation, staple seems to be more efficient when they start early on, but approximately by 2 weeks, they substituted by the 8-plate that's proved to be more efficient in produced deformity. These findings are similar to the ones of Gottliebsen in a porcine model, where they found that there were histological changes that were absolutely identical in the 8-plate model and the staple model at 9 weeks, just after epiphysiodesis, and at 14 weeks, 5 weeks after the removal of the staples. If we look from a clinical point of view, there have been a number of reviews just comparing both methods. I think the most important papers, probably one because it's the most recent one, is a systematic review of the literature. It was unable to prove any difference in time angulation or complications between staples and 8-plates or tension band plates. And there is another work that is probably interesting because it's a prospective randomized study where compare patients treated with tension band plates and with the staples, and they couldn't observe any difference in the time in angulation or pain scores, and they couldn't see any hardware failure. So I think that in summary, we can say that the 8-plate acts by a similar mechanism as the staples, but it works in a more progressive way, just giving more time for the growth plate to growth. It's important to keep in mind that growth at rest has never been described in hemiepiphysiodesis. And there is no doubt that the mechanical stability, bond purchase, and easy to handle is far superior in the 8-plate than the staples. But the difference in price between one system and the other, it's big enough to be able to say that you can still use the staples if you don't have the resources for using a tension band plate, and you will still be doing an adequate treatment. And that's the conclusion for the literature.
Okay, so like in this point, almost we all are clear, like the faculty and everyone were favoring the 8-plate, and literature also supports what they felt. So I think probably there is no much discussion or the controversy on this, and we move on to the next topic. Just one query, like, are we going to discuss knee flexion deformity in the subsequent point? No. Because there was, yes, we are going to discuss that. Okay, so there was one comment by one of our senior member, that for the knee flexion deformity, staples are better than 8-plate because they are low profile. But we are going to discuss that point when we come to knee flexion deformity. Okay, so let's go to the second point.
Okay, it's a boy, age 10, who has a knocking knees. The parents are very concerned. We tell them that it's on the limits for surgery, and the only thing is if he had pain, we would consider it seriously. So he came 1 year later complaining of anterior knee pain. We don't know if because of the suggestions to the parents. And the question to the panel here is whether you're going to use 1 8-plate or two tension band plates, or are you going to use a quad plate rather than a single plate?
Okay, so Manoj, like you take this question first.
Yeah, so my preference would be just a single straightforward 8-plate. I don't see any specific benefits of putting 2 plates. I don't have any experience with a quad plate, but I think a single 8-plate is more than adequate. Placed in the mid-coronal plane should do the job. So I've had good clinical results, and as far as I'm aware, there is nothing to say that a quad plate or 2 8-plates are superior than a single 8-plate. So my preference would be a single 8-plate.
But suppose if it's a 14-year-old boy who is relatively obese with a BMI around, like, say 30, in that case, what will be your take? Still you will go for 1 8-plate, or you will go for 2 plates?
I mean, my concern at that age would be whether there is adequate time remaining, but I still would be, a single 8-plate would be what I would use.
Okay, right, fine. Taral, what do you think about this?
No, I agree with Manoj that most of these patients, we have used a single 8-plate with 2 screws, and I have not used quadrilateral plate, or I have not used multiple 8-plates.
Okay, so probably this quad plate is not yet available in India freely. So only option 2 is like 1 8-plate or 2 8-plate. But still you say that you will go for only 1 8-plate. Okay, right. Peter, what do you think? Do you use 2 plates, or you still use 1 plate?
No, a single tension band is all you need. And remember, you're putting the implant on an intact bone, and the implant doesn't know what or care what the BMI is. So my personal best is 185 kilograms, 15-year-old, and I use single 8-plates, and I've done many patients who are 150 kilograms. The failure rate is not proportional to the BMI, even in Blount's disease, which we may discuss later. So I have no use for the quad plate. Perhaps I could send those to somebody in India if they want them. It's not necessary. And I agree with the comment made about positioning for x-rays, that you may be misled if there's a lack of correlation between what the mechanical axis on the x-ray and what you observe in the patient walking in the clinic, then you treat the patient, because the x-ray can be misleading when they're standing at attention. For a patient like this, I might say, in the past, I've said, come back in a year or when you're concerned, and we'll take another x-ray. What I do now is say, send me a picture periodically of the patient standing in shorts or a swimsuit, and I'll tell you whether I think it's worth coming back.
Okay, so yes, Ignacio, yeah, you can continue with that.
Okay, so I only found 2 articles on relation to the use of a single or more. The most old article is the one of Blount, who already suggested in his article of the preliminary results about epiphyseal stapling that if you were going to use a single staple, you will get better correction, but the problem was mechanical failure. So we did a histological study just checking what was the difference between 1 staple, 2 staples, and 8 plates. So, and what we see is that when you use a single staple, you get more angulation than when you use 2 staples. And the explanation for that, to me, it's quite easy to understand. It's if you have 2 circles and you join the circles by a single point, you would be able to move freely both circles around a single axis. But if you put double tether, then your limitation on opening the circles will be determined by the distance between the 2 tethers. And this will forcibly limit your ability to increase the angulation. So it's clearly superior to use a single tether. And in fact, when we translate all the possible combinations, we saw that's one of the reasons why the 8 plate is more effective than staples. It's just because it uses a single tether rather than multiple tethers as does the staples. So in conclusion, in angular deformities, a single tether is always better. And although double staples may be faster initially, they produce eventually less deformity. And however, having said that, in the clinical, there is no evidence of difference in the speed of angulation between staples and tension band plating.
Okay, so I think there is again like no controversy in this point, and we can move on to the 3rd point. The viewers who are putting their questions, definitely we will take the questions once these controversies are over. Like then there is one question by Avi. Will quad plate, just a minute, let me see that because it was relevant to, yeah, the question by Avi was like, will quad plate be better for limb length discrepancy correction compared to 8 plate? We are coming to that point again. So Avi, please wait for a minute. We are coming to that point. Yeah, let's move further. Yeah, Taral, please.
Yeah, I have a question about the years. So at 10 years, you decided to wait, and then you did, at 11 years, you decided probably some surgery should be done. We are facing now patients here where, at 10 years, you ask the patient to wait and see if the deformity is increasing. And when you see at 11, the growth plate is already fused. This is especially true about girls in India. Many of the girls have premature sort of a skeletal maturity, and they close their growth plates very early. So that is one question which is really troubling us, and we wanted to know from the experts here, what is the age at which you do this surgery? How early or how late? If you do it too early, there is a chance of rebound growth, and if you do it too late, the growth plate would be fused. So how do you decide when to operate? So I'm just keeping this open for discussion if we have some time.
Ignacio, would you like to take this question now, or shall we keep it for the last part of the questions?
Well, I think that's one of the nice things, what I like of guided growth, and I can intention band plating. That's if you go early, you have time enough, even if you have problems after. I think one of the things that we have to walk away is on the classical concept of wait too long, just in case that's going to be a growth arrest. That was the big concern when we were using staples. And I think I have to say that tension band plating has changed this concept. That's to me, I'm not so concerned. I would rather go early and have to repeat than go later and have to regret it.
Okay. Like Professor Barne with us, so would you like to say your comments on this question, like what will be the right age about the growth modulation for the angular deformity? Yeah, please, Professor Barne.
Is it me? Yeah, thank you. First of all, I have to apologize for coming in late, but going to the question, this for me, I like to go in as early as possible, and as Ignacio told us, it's better to repeat than to be too late, and so this is my primary when I'm talking to the patients. Go in early and maybe repeat.
Okay, right. So again, I think most of us agree on the point that it's better to do it early rather than to do it late and then regret that now there is not sufficient time for correction. So again, that's a very important practical point. Yeah, can we go for the third point? Manoj, would you like to ask a question or?
I think I'll bring up some questions as we move on to the next case.
Okay, right. Yeah, thank you. Please, Ignacio.
So we're going to go now to leg length discrepancy, and we're going to discuss a number of cases. So let's go to start with the first case. That's a child, age 14, that is referred by his GP, but because he has noticed a small leg length discrepancy. On examination, he has a leg length discrepancy of 1.3 centimeters. That's symmetrical between femur and tibia. He's a boy, he's 14. Just turned 14, what will the people do? Will discharge the patient or will follow the patient? First question.
Okay, so like this one case has a lot of sub-questions also, because the deformity is both in the femur and tibia. So now the first question is like, should we operate this patient because it's only a 1.3 centimeter? That's the first question. And second, if we decide to operate, whether we should do it at femur or we should do it at tibia, that's the second question. So I request Taral to give his opinion first on this point, and then we will ask Manoj, then Professor Barne, and then last Professor Peter Stevens. Yes, Taral, please.
So he's a 14-year-old child with the 1.3 leg length discrepancy. So one issue is that, this is not going to increase too much. At age of 14 years, we are not expecting much increase in the limb length discrepancy. So here, it depends on the child's comfort. If child is comfortable walking, I would just accept this, and tell the parents that the incidence of back pain is not higher in children who have limb length discrepancy less than 1.5 centimeters. So if sometimes children don't even notice, if the parents have not noticed, it's absolutely fine to have, not to operate these patients and treat conservatively. If this needs to be operated, then since the majority of the limb length discrepancy is in the femur, femur needs to be done. And here, my choice for correcting limb length discrepancy is to use 2 PET screws, rather than using 8 plates or staples. That's my choice.
Okay, right. So first of all, there is no indication in this patient because it's only a 1.3 centimeter deformity. Just a counter question, at what point you would consider to correct this limb length discrepancy? At 1.9, 2.3, 2.9, at what point you consider for the surgical intervention?
So if the pelvic is oblique, if there is a pelvic obliquity and there is a noticeable gait difference and symptoms, then I would correct it, not otherwise.
Okay, so not on the number, but
is more than 1.5.
Okay, right. Yes, Manoj, what is your take on that?
Yeah, I mean, I agree with Taral to the extent that this is not going to end up as a significant leg length discrepancy at the end of growth, so this is going to involve a lot of discussion with the family as to what their views on it. Whether purely from my perspective, I don't think this needs correction. Because this is going to be less than 2 centimeters, the final leg length discrepancy. But this is something where I would have a lot of discussion with the family as to what they feel about it. My objective of correcting would be that I would want to kind of leave it slightly under-corrected, because this is likely to be a long-standing length discrepancy. So I would just aim to correct just the femur to get it to probably about, to end the final discrepancy to be somewhere around 0.5 centimeter or something like that. And I would also prefer to use a screw so that I don't have to kind of, it's a smaller incision. It's easier to kind of leave it in there so that I don't have to take it out. That would be my preferred view. But I would probably not intervene. That would be my first line.
Okay. So what is your experience about the pain following surgery with the 8-plate and the percutaneous screw? So like, is there any difference in the postoperative pain the patient has?
I think with the percutaneous screw, the local site mobility is much lesser. They're up and about a lot sooner. Whereas with the 2 8-plates, I find them sometimes they can take a little while to get going and to feel comfortable with their quads. Whereas with the percutaneous screw, they're up and about pretty much the next day and pretty much back to full functioning very quickly. So the local mobility is much lesser.
Okay. Now another question is like, if you do at the femur, then if we are able to correct it well, in that case there will be a difference in the knee level. No doubt it will be few millimeter, but are you really worried about that difference in the knee level?
I don't think up to about the joint level being at 2 different levels would matter. Up to probably about 2 centimeters. So I don't think in this particular case I would be concerned about it.
Okay.
But
right,
for larger
yes.
length discrepancy, that would be a factor.
Okay, right. Yes, Professor Barnett, what do you think? What is your opinion for this case?
Thank you. I think that looking as my colleague is telling me that for sure, if there's no symptoms, it's you find this discrepancy in your outpatient clinic and the patient have no symptoms at all, I'll do nothing. But if they have symptoms, I'll follow them. And if you have already had mentioned, if we are passing 2 centimeters, of course, we have to tell the parents that we are shortage in time because the age is 14 years old. So basically, I think I prefer conservative treatment. But if it's running out of what we can call non-symptomatic and it will be symptomatic, of course, we have to do something. And my choice is that I usually use a 6 millimeter drill, or nowadays we're trying to use the radio frequency ablation as an option now. But the last one is still, it's experimental for us still. But basically, as this case is shown to me, I'll try to use non-operative treatment to the kid.
Yes, Peter, what is your opinion about this case?
So I agree, this is a borderline case. We've become complacent based upon the literature that 1.5 centimeters or less is acceptable. But bear in mind that literature was from young, healthy military recruits where there was not long-term follow-up. There is some data emerging that even lesser discrepancies may be a problem as people live longer. And my colleague, Dr. Iona at the Shriners Hospital in Portland did an interesting gait lab study showing that even lesser discrepancies affect the gait. So I've been complacent as well. And this family, I would say, this is acceptable. It might reach 1.4 or 5 centimeters at maturity, which is borderline based on our literature. And if he had symptoms, I wouldn't treat him. The flip side is that if he presented because of symptoms or they have a lot of concerns, I wouldn't withhold treatment. And, I tend to favor a pair of tension band plates. I acknowledge the pain is more for the first month, and then it's equivalent after that. My concern about the screws is the possibility of asymmetrical arrest and therefore varus or valgus requiring osteotomy, and also our limited ability to judge skeletal maturity, plus or minus 1 year in many studies, so that you may be off, and I won't show it here, but one case where he had Beckwith-Wiedemann syndrome, which is different, I recommended tethering at age 10, and at age 12 or so in another city, they had drilling, permanent closure, and he developed 6 centimeter overcorrection and had to have a lengthening of his other leg. So I'm wary of our ability to really predict things, but I totally agree that the parents play a strong role in whether to proceed or not.
Okay, so to me, the concern is whether that is a static or a dynamic deformity, meaning that it's going to remain like this or it's going to increase. So the patient was given a follow-up at 10 months, and at 10 months, his discrepancy has gone up to 1.9 centimeters, still symmetrical. And when we do the predicted length, now his expected leg length discrepancy, it's 2.3 centimeters. So just to give some information, he's now 15. So if we do an epiphysiodesis of the femur, we will get 1.5 centimeters growth arrest. If we do the tibia, we will get, if we do both, we will get an extra 0.9. I remember that he's 15 and his leg discrepancy is now 2.3. So what you will do now and how?
Okay, so now again, let's start with Taral. Like initially you said that it's less deformity, so you're not going to operate this child. But now the predicted limb length discrepancy is more. So what would you do now?
So, Indian teenagers, don't follow their parents and don't follow the growth charts. We've seen that most of the children, the growth shuts down by 15 years. Most of the girls, it will shut down by 13 years. And though this is multiplier method and they've shown that it works over different ethnicities, it's our experience, especially my experience, that after 14, there is hardly any growth left in Indian boys in terms of increase in lower limb growth. So if it's the same age, then, I won't depend on the multiplier chart. I would get the elbow x-rays done and actually look for the bone age and skeletal maturity before taking any decision.
Okay, so how will you take a decision in that case? Like after the elbow x-ray, how do you decide whether to go in or not? At what point?
So if elbow x-ray shows that the olecranon is shut down, it's closed, then it's unlikely that this 1.3 centimeter would increase to 2.1 in that patient.
Okay, right. But if the x-ray says that yes, the growth is remaining in that case, so if the situation is...
So I was looking at the x-ray. So can you go back, Professor Ignacio, one slide back? Sure. Yeah. So there is one very important point which this scanogram has shown. And if you look at this x-ray...
No, sorry. I don't think... Yeah,
we can see that. So we see that the hips are at different levels. But if you see the spine, it is completely straight. So that's a very important consideration for me. And we also do gait analysis because I have access to gait analysis. And if I see not much difference in the truncal sort of a shift, between as the child is walking, then we will not operate that patient. So I stand back by my sort of suggestion of not doing a surgery for Indian patients at that age.
No, but like if we come to the situation which is given over here, let's say that the Indian patients are 1 year smaller than the case which we are discussing.
So if this was 13-year-old and growth plate is open and there is chance of increasing, then I would offer surgery for that patient. And my choice would be to do femoral epiphysodesis using screws in that case. In tibia, if you compare tibial epiphysodesis versus femoral epiphysodesis, tibial epiphysodesis is less predictable than femoral epiphysodesis, and it is also more painful than femoral epiphysodesis for some reasons.
No, but Taral, if we are doing, then why not to add one more surgery at the tibia and try to get as much correction as possible, rather than to...
The tibial, I found patients have more pain. So there is a difference in pain between doing hemi epiphysodesis and complete epiphysodesis of femur, one where you have one plate versus two plate. But if you have 4 plates, 2 in femur and 2 tibia, these children have tremendous pain in the upper end of tibia. This is what I have observed. So, we refrain from doing it. For tibia, I don't use plates, unless there is a reason to do it. I prefer screws again for tibia.
Yes, Manoj, do you agree with what Taral says, or you have a different opinion?
So I would agree partly that the experience that we have with our children, that we do not have extended growth, till 16, 18. We find that they stop growing a lot sooner. So I do not know how reliable the multiplier data would be for us, but yes, I do use it in my practice. So for the sake of the discussion, if I were to if this was going to be the predicted difference, I would definitely consider epiphysiodesis of the femur. My objective is not to get it absolutely equal. I would leave it undercorrected. So if the predicted discrepancy is going to be beyond 2 centimeters, that would be an indication for me to intervene. And like I said, my preference would be a screw, and I'm for the femur. I understand Dr. Stevens' concerns, but that's what I would prefer, and I would not remove the implant. I would leave it because I'm pretty sure that it would leave it undercorrected, slightly undercorrected.
Okay, and you will not add anything to tibia?
No, I wouldn't, because I'm the objective here. I'm not trying to get it absolutely equal. I'm happy, because I think a lot of these are long-standing deformities, and leaving them slightly undercorrected is probably better. I found that if you do a block test and if you get it absolutely equal, they find it longer. Whatever you measured it, and if you put exact block, they would actually find that leg to be longer. So I don't want them to be equal. So I would do what you call a functional equalization. So I'm not going to measure it exactly. I would leave it slightly shorter. So my preference would be to leave it shorter with just a femoral epiphysiodesis. And coming to the point, this is one of the things which again, Taral brought up about, again, I would want the faculty's opinion. What are the various, suppose we have this, difficult situation wherein the physis is not very clear. We are not sure how much growth is remaining. What do the various faculty use? What are the adjuncts? Do they use skeletal age, or they just rely on chronological age? Do they rely on elbow x-rays and soft grains method? Are there anything else which they would rely on, or is it just chronological age? That would be something which I would want to know from the faculty for both angular correction as well as leg length discrepancy in these borderline ages.
Okay, yes, Peter, can we have your opinion about this case?
Yes, a comment about the multiplier act, which is convenient, but it says entire leg. It means femur plus tibia. It does not include the foot or the ilium. So bear that in mind. You may underestimate some of these things. I think it's a bit optimistic, even in Utah, that a 15-year-old could get 2.4 centimeters of growth because the growth is tapering. So I would offer the family the possibility of undercorrecting, doing just the femur, and accepting undercorrection rather than the tibia as well. I agree the tibia is less predictable. The alternative is see him at maturity, have him wear a 2.4 centimeter lift or whatever you think is different. And if he likes that and feels symmetrical, you could do a femoral shortening. I mean, I could tell the family that there is, albeit a larger surgery, there is a quote definitive surgery that's not time sensitive, that can be done anytime after maturity if he is symptomatic.
Yes, and about the question of Manoj, when there is a borderline case, in that case, in addition to multiplier method, do you use something else for determining the skeletal age of a child? Yeah, Peter, question to you.
Oh, that question's for me?
Yeah.
Yeah, so even though I'm skeptical of bone age, in fact, I do use it with encroaching maturity. So for this boy who's 15, I would take a hand film, and if the distal phalanges are still open, meaning I think he has at least a year to grow, that's when I would offer this treatment. So with encroaching maturity, some form of bone age determination is at least helpful, albeit not always accurate.
So you use the hand X-ray for that, not the elbow X-ray.
Right, I'm just more used to the hand X-ray. I'm well aware of the elbow work by Dr. D'Amiglio, and I respect that. But in our clinic, most of us still use the hand. And Dr. Sanders has refined that. It's used a lot by the spine surgeons to either pursue it even further. But mine is more of a gestalt.
Okay. Yes, Barney, what is your opinion about this case?
Yeah, well, you see, it's still a borderline, and I expect that that the physis is open, and I will take an X-ray of the hands, maybe more because of the law here in my country. I have to do that. Otherwise, as looking at that child, I will do a distal femur epiphysiodesis, and I'm not expecting that we will have to that the legs will equal in length, and I'll tell the family that this will not be expected. So I will do a distal femur epiphysiodesis, although maybe the child do not have any symptoms at the time where I see the kids, but this will be my option for this family.
Okay, so you will not use any implant and you will go for a permanent procedure for this case.
Sure. Yeah.
Right. Yes. Yeah. Okay. And Peter, we did not ask you about your choice of implant for this particular case, the screw, 8-plate, or a permanent epiphysiodesis for the femur.
I would likely use the 8-plate. And if you were wrong in your calculations, there is an escape route by removing the implants. And if you're correct, and he reaches maturity and is not symptomatic, they don't need to be removed.
Okay. So like we have a lot of questions on this, and I'm sure that we have a difference of opinion on this also. So Ignacio, we are really keen to understand what the literature says about this. Yeah, please.
Well, before we discuss the literature, we will go in another number of cases and then discuss all together, because I cannot just take topic by topic. So in this case, what we did was an epiphysiodesis of the femur, and we did a funny combination. We did a percutaneous epiphysiodesis, but we use on top percutaneous transphysial screws. Reason, there is literature that shows that the percutaneous epiphysiodesis may take up to 3 months to act. So we were very short in time, and we tried to match the things. So 6 months, 9 months later, his discrepancy is down to 1 centimeter. Okay, next case, it's a girl, age 9 years and 8 months. She has a club right foot, and his right leg is short. The leg, it's funny, it's a bit thinner, not only on the shin, but also on the thigh, and has an absence of the right anterior tibial action or muscle. His MRI, central MRI, head and spine are normal. She has some small deficit on learning, but she's otherwise a clever girl, and her leg discrepancy is 3.7 centimeters. So she's 9, plus 8, and she has a kind of paretic leg on the right side, and his leg prediction of discrepancy is 5.2 centimeters. So the question goes for the panel. What will you do now?
Okay, so let's start with the Peter first. Like, what will you do in this case? The predicted limb length discrepancy is 5.2 centimeter. So I don't think that there is any controversy about doing a surgery. The major question is about which implant. and which technique will you use? Will you go for a permanent epiphysiodesis with screws like as shown in the last case, or still you will go for the 8-plate or a percutaneous screws? Yes, Peter.
So that's a rhetorical question for me, but I would start now. The major discrepancy is below the knee, including her foot and her tibia. And again, you would miss the foot on a scanogram, and it's not implied in this results. But if you do a standing AP of the ankles, you'll see that the plafond is closer to the floor. So, you know, the major discrepancy is below the knee, but that won't give you full correction at maturity. So what I would do is pan-genu 8 plates on the left side, knowing that at any time you can take the implants or the metaphyseal screws out of the femur as she gains better correction. And again, you might not want full equality if this leg is weaker, et cetera, that, you know, I go to bring it to within a centimeter if possible at maturity. So when I put in pan-genu 8 plates, or even when I use 8 plates for length, in either case, two comments. One is, yes, there's a lag period. So I diverge the screws upon insertion, so you don't have central growth. And the other is, what about pagoda tibia, which is overstated? If you diverge the screws, you'll probably avoid that. The third thing is I don't do anything to the fibula here because it's not prominent. So I ignore the fibula. So starting at age 9+8, I would do pan-genu, see her twice a year, adjust implants as needed for angular deviation or to remove the femoral ones sooner than later.
Yes, Manoj, what will be your take on this?
I agree with Dr. Stevens, and this is one instance wherein I wouldn't do a screw because I would want the 8 plates because I want to have the option of reversibility. I need to be absolutely certain, and I think Dr. Peter would agree with me regarding that. You know, he would remove the metaphyseal screw by 2 years, or even if the correction was, even if the correction is not complete, so that you give the physis some amount of, a breather to kind of grow and then reinsert it as needed. So pan-genu epiphysiodesis with 8 plate would be my option.
Can I make a quick comment on the timing?
Yeah, please.
So for angular correction, there is no limit. And I think Dr. Sanpera would agree in his rabbit studies. Because you're only restraining one side of the physis. But for length, the honor limit is up to 2 years, whereupon I remove metaphyseal screws or the entire implant, wait 6 months, reinsert the screws. And upon searching for that, the only evidence I could find was a personal communication between Dr. Femister and Dr. Blount. It's never been corroborated to my knowledge in the literature, but none of us would want to be proven wrong and leave something more than 2 years and have a permanent arrest. So it's empirical, but in honoring that, I've not had any premature permanent arrests for length.
Okay, so like one of the empirical practice which we are doing is like we tends to remove the implant at 2 years with the idea that we want to give some breathing time to the growth plate. So probably we need more literature or the research on this point. But before we come to that, Barney, what do you think about this case? You need to unmute yourself.
Well, you see that's H9 and with this clubfoot and a shortest we can expect 5.2 centimeters. I will put on some plates, but and then follow the kids by x-rays and maybe take away one of the screws as mentioned by Peter Stevens. But I have a problem with course I have seen some of this volcano effect, and my question is that I don't know, but my question is that maybe it's connected to how I put in the screw in relation to angles, or is it the length of the screw? I don't know, but this would be interesting to hear from you. But I'll put on plates and follow the kids and then remove one of the screws and then repeat if possible. But I would like to know, does it mean anything concerning the length of the screw we use and angulation?
Can I answer that?
Yeah, please.
So I use the longest screw available just in general. So there's less chance of it drifting, especially in the tibia. The tibia, even with 8 plates, may drift into varus more likely than valgus. And if it does, I remove the medial implant for a period of time, let it neutralize and put it back in. But I found that early in my practice, when I put parallel screws in for length inhibition, they would diverge X amount of time, which means I'm wasting time. And the theoretical central growth could produce the pagodotibia. The flip side is that since I've been diverging the screws, and we did a pretty large series of review and did not find this to be a problem. Also, where in the articles where it was noticed, it hasn't seemed to be of any clinical significance. There's no knee instability. There's no interarticular pathology that's been demonstrated or had to be addressed. So it's mainly a radiographic finding that's interesting and perhaps concerning, but not proven.
Yeah, please.
Yeah, well, that's
please
good
go
to
ahead.
hear, Peter. When you say you use the longest ones, what does that mean actually? Are you passing the middle of the bone? This is one question. The other question is that I agree with you. I have not seen any clinical, that it doesn't mean anything into the clinical life, what we see on the x-rays. But of course I get concerned, but I would like to know concerning the screws, do you pass the middle of the bone with both of them?
Well, the longest screw in the 8-plate set is 32 millimeters, which in a smaller child would pass the middle, but it doesn't have to. If you feel that's important, you can take a stainless steel screw and put it in a titanium plate with no downside. So in some of the skeletal dysplasias, if the longest screw is dislodging, I would put in maybe a 50 millimeter screw. You know, there's no limit to what you could do. Whether it's necessary, I don't know.
Okay, I agree with you. You see, but for me, it's a little bit experimental, but that's what I do. I use the steel screw, and I'm passing the mid axis, of course. But it's good to hear that you have a better experience than I have.
Well, if you're using a stainless steel screw, there's no downside to using a 3/5 screw, which has a small head, which takes care of any prominence concerns for some applications.
Yeah, I agree.
But you won't get metallurgy battery effect. You know, that's kind of overstated. I've not observed any downside to mixing hardware when it was my best option.
Mm-hmm.
Okay. Yes, Carol, what is your opinion about this?
Yeah, so no, I agree with everything said, but I just want to convey one more point, is that Peter very rightly said that it's not just length of femur and tibia matters, and he added that the heel length will change. I want to go one step further, and I want to say that even ilial lengths matter. What is the purpose of correcting limb length discrepancy? You want to avoid issues with an oblique spine. And what I actually do is, draw this line which joins the S1, L5, S1 junction. And then I would calculate the limb length, all the way from there till down. And this way I find is the amount of limb length discrepancy which I want to correct is not just in femur or in tibia or in the heel and the foot, but also in the ilium, the pelvis bone. And the only problem is the places where you can adjust this are only two: the lower end of femur and upper end of tibia. Okay, so the deformities, the disabilities are differences at many places, but finally it gets to resolve between femur and tibia only.
Okay, so in how many number of patients have you come across this component of deformity, the foot component and the ilium component in the overall limb length discrepancy cases?
So if you have hemihypertrophy, it is universal. In fact, in hemihypertrophy, even one side ilium is bigger than the other. Recently, we had a case where the L5, one side pedicle was bigger than the other. So it sort of grows into the spine also, the hemihypertrophy. And if you don't notice these things, you will end up with undercorrection and still having some amount of scoliosis in spite of doing a surgery. So you need to look at the child overall and entire limb and pelvis. It's not just femur and tibia.
Yeah. Okay, good point. So not only the femur and tibia, but we need to look at the whole limb for the limb length discrepancy. Right. Okay. So Ignacio, now can you enlighten us more about this?
Well, again, one word of caution about joint deformities. I mean, we're saying the joint deformities doesn't have any consequences, but we looking just a short term, and we don't know what will be the significance in long term. So I think we have to be very careful about the judgments that we do. That doesn't matter, because we can find that later on it has consequences, and nobody can say at this moment. So that's one of the problems that I find. But anyway, just carrying with that, what we did a pan-general epiphysiodesis, and you can see at 1 year, the discrepancy went down to 2.2 centimeters, and just by nearly 2 years, not reached 2 years, she was nearly back to normal. So we removed the tension band plating, and she's now free, just hoping to give her some extra growth on this side to leave the leg slightly shorter, the short leg slightly shorter, as Peter pointed out. Okay, so I will go to the
just
next
one
case.
Question. Before that, I have one question. Like when you said that you removed the tension band plate, it's the complete, all the implants were removed, or only one metaphyseal screw was removed?
We had quite a few bad experience with the 8 plates just by removing only the metaphyseal screw. So we removed the whole 8 plate because we think it doesn't increase much our surgical time, and implanting a new plate, it doesn't create much of difference between one and the other operation. And we had 2 bad experience with 8 plates left inside. So that has changed our mind about it. So we removed the full plate,
Yes, Barney, your comments, please.
Well, yes, it's interesting to see, Ignacio, that your screws is maybe only 1/3 of the bone. So you don't have any problems with short screws or what?
No, we haven't had any problems. In fact, we work on the experimental side, whether length of the screw matters on the action of the growth plates. It seems that shorter the screw, more effective is the effect, especially in angular deformities. But you have to counterbalance that against mechanical stability. And it has to be said that some things that we look and measure in experimental models may not have relevance in clinical practice. So we have to be careful about how we translate our research to the practical terms, but we tend rather shorter than longer, except if it's a weak bond for some reason.
Yes, Ignacio, there is a question by one of our member that you said that you had some problem with 8 plate. Can you tell us more about that problem, because we would like to understand about that?
Okay, I have a case, so I show this case. We're going to be a bit short of time, but maybe either I can go to the case, or we can carry on.
Let's continue the flow in which we are going. If required, like we will come to the next session sometime in future also. So don't worry about time.
Okay, so that's our third case. Is a Perthes disease. He had Perthes at the age of 5. He was loose on follow-up at the age of 8, and he's referred back by his pediatrician. He's now 13.10, and that's his X-rays. He has a leg discrepancy of 2.3 centimeters, and he has a left coxabara with overgrowth of the greater trochanter. So, sorry, just opinions. What will you do in this case? He's 13 years, 10 months, European 13 years, 10 months, not Indian ones. Okay, so still growth remaining. And I would like to know your opinions.
Yes, so basically what Professor said, we will follow that, we will consider that as an European child with a growth remaining. So we will not bring the Indian context for the discussion point of view. Yes, Manoj, what do you think? Now, what will you do in this case?
Yeah, so there are two aspects to it. So one is, of course, the coxa, whether that needs correcting, and so I can't make out from this X-ray, so I'm not going to discuss that. So this is somewhere where I would offer, because this leg-length discrepancy is significant and it's likely to get worse. So I would offer a contralateral distal femoral epiphysiodesis. And this is, and here, I don't think you're losing anything. Whether there is growth remaining or not, you would want to kind of, whatever correction that you can achieve in terms of length should be corrected. And therefore, I would definitely advocate contralateral distal femoral epiphysiodesis.
Which implant? 8-plate or screws?
So I don't think there's any kind of specific rationale in my mind, but where I think that, I would want kind of, where I don't anticipate having to kind of remove the implant, that I don't want reversibility as my prime this thing, I would probably err on the side of putting screws, percutaneous epiphysiodesis with transficil screws. Whereas where I think the younger child who needed the pangenoid epiphysiodesis, there I would want the 8 plates. I think, I'm prepared to be corrected on this. I think the leg length discrepancy is better corrected. There is some evidence with transficil screws rather than 8 plates. There is some kind of review on different techniques which have shown that there is slightly more quicker correction or something to that effect. So for that reason, I think I would go for a screws in this case.
Okay. Yes, Balne, what is your take for this case?
Yeah, thank you. Well, of course, the diagnosis at the hip, of course, but as my colleague says, we have to do something in relation to leg length discrepancy, and I would use 8 plates, but I'm a little bit concerned about the 8 plate here because at that age, and you want to be sure that you place this 8 plate in the correct position. I put 2 plates in parallel, but this is because I have bad experience, but I would like to discuss how important is it to exactly place this 8 plate in the right place in relation to not going too far back, not going too far anterior, and what is the window? How many millimeters do we have to work on this? Because I saw one of those in my clinic where actually there was a little bit angulation at the growth plate, and this was because what I think that I have placed the plate a little bit too anterior. I would like you to make a note on that too. But I'll use 8 plates here.
Right. Okay. Yes, Taral. And then we will ask Peter. Yeah, Taral, please.
I have a different point of view. There are 2 conditions where I would accept leg length discrepancy. One of them is a spastic hemiplegic cerebral palsy, where it is better to have the limb shorter, or polio affected limb. It's better to have them shorter for the clearance. In case of dysplastic hips and perthes, I would have the limb shorter, and I'll explain to you my point of view. The reason is when you have a shorter limb, the pelvis moves down, and the acetabulum covers the head, which is enlarged. Now, if you were to correct the limb length discrepancy completely in this patient, what happens is the pelvis gets parallel and the coverage effect of the acetabulum becomes less. And that's why it is advised that even if you're correcting limb length discrepancy in this patient, don't completely correct it. Leave some shortening behind and you'll have a better gait. If you have exact correction of limb length discrepancy in this case, then probably you will have a better looking scanogram, but gait would be not so good in that patient. And the second point I want to say is there is no coxa in this patient. It's more of a coxa breva because neck shaft angle is fine. The trochanter is a little bit overgrown, but still it's at the center of the hip. So, it's a shorter neck, but not a varus neck in this patient.
Okay. Yes, Peter, what is your suggestions for this case?
So I agree with Terrell, and that's coxa brevis. If he had a Trendelenburg sign, I would combine it with distal transfer of the trochanter. But regarding the right leg, I would use 8 plates in the distal femur, and I agree with the concerns about placement, that some patients have some recurvatum naturally, and if you place the plates anterior to midline, you may exacerbate that. So I emphasize in training the residents and fellows that you want to be mid-sagittal, or if you're going to err posteriorly. I've never knowingly produced a flexion deformity. I think flexion is, posterior is more forgiving. So I use one plate on either side. Mid-sagittal is ideal, and expect, he may not get full correction. Although, as you know, in Perthes, the bone age is sometimes delayed. They may grow a year or two longer than their colleagues. So those are my comments.
Okay, yes, over to you, Ignacio.
Okay, so we decided to do growth plates around the distal femur. We put our screws wide open just because we want to stop growth. And that's what's happened 10 months later. The discrepancy is now 2.6. The child is growing, but we haven't managed to do anything with our 8 plates. So the discrepancy has gone from 2.3 to 2.6. So my question is, what are you going to do now?
Before we go in, so can you explain the situation again, or are you sure about what is happening? It's just measurement error, or it is something else?
Well, what we did, it's 10 months ago, we did epiphysiodesis with tension band plating on the distal femur. And now he comes for control, and we took a new X-ray. Now the leg discrepancy, it's even bigger, and it's growth in both femora and it's growth in both tibia. So it's not a question that is not growing. It's a question that we're not succeeding on inhibiting growth.
Okay, a very interesting situation. Yes, Manoj, what will you do now? It's really a tricky situation, and it's very embarrassing for surgeons to answer questions at that particular time to the family.
So I mean, this is certainly unusual. I think if we could compare the previous system, there's been no change in the screw divergence. So one would assume that the 8 plates are not doing their job in terms of controlling the growth. So this is where I would I'd be interested to know what Dr. Stevens thinks about it as to why it is not stopping the growth. Now we have a situation wherein you probably would want to revise it, and because the child is older, whether additional 8 plates is the way forward, or whether you want to do the tibia as well, to make up for the remaining discrepancy. So that's the way I'm thinking, but I don't have an answer to that.
Okay, right, yeah. So, Barne, what is your take on this? What is the cause and what will you do now? Yeah, please unmute yourself. Please unmute yourself, please.
Yarne, the boys.
Yeah, this is of course a case where I said, wow, what to tell the parents? But it's biology, but maybe I would like to still discuss the length of the screw could be maybe one of the options, but what to do with the kit, of course, I'll do as fast as possible an epiphysiodesis at the lower leg of the femur. And then I do not expect that we will equalize the length, and that's what I do. I think we have to do something. But I would like that we discuss that. Why did this happen actually? Is it because of the length of the screws, the plate, the length of the plate, or the angulation? So, but I'll do epiphysiodesis as fast as possible to make it maybe a bad story, a better story.
Okay, right. Yes, Taral, what is your take on that? The reason for this situation and what will you do now?
So this is a very tricky situation, but what happens, parents' point of view, moment you put an 8 plate, the next month when they come for follow-up, they want to know how much correction happened. कितना correction हुआ. They are expecting that your surgery will start working immediately. And it's very important to educate the parents that the first correction apparent correction will not happen before 3 months. Even for angular corrections, the midline discrepancy, when I've actually measured, I've seen that most of our patients don't correct much before 6 months of age. So, I would still wait. If it's 8 months post-surgery, you would wait for a few months and see if it's still occurring, if you are lucky. If not, I would, remove the plates and convert into a complete epiphysiodesis. So I wait till a point that complete epiphysiodesis is possible. In this case, at this age, since distal femoral epiphysiodesis would produce 1.8 centimeter correction, so I would remove the implants and do a distal femoral epiphysiodesis and plates for tibia at that time.
Okay. Yes, Peter, what do you think on this?
So this is foreign to my experience, and I'm hard pressed to explain it. I don't know if there was a notable tibial discrepancy at the outset, but I guess in the interest of diplomacy, with the parents looking at the x-rays together, I would say, your son has very powerful growth plates and this technology is not working for him. So I would likely take these out and actually, dare I say, drill the distal femur and the proximal tibia and I would take a hand x-ray, but at age 14 plus 10, I don't think that you would get overcorrection. I think you'd end up okay.
Okay, right. So do you think that one plate is not able to work in this situation and probably the 2 plates would have avoided this situation? Do you think so?
I've never used 2 plates, but I've never seen it increase after in individual bone after plate insertion. I would have used longer screws thinking, well, maybe the surface area is better, but I don't know whether that's really an issue or not. And when you use plates on both sides, you don't expect further diversions of the screws. If you see that, there is central growth that's producing that, but that's not an expectation for angular inhibition or for length inhibition, I'm sorry.
Right, yes, over to you, Ignacio.
Okay, so what is now 15 and it's not my patient. I can explain what they did in my team. So they decided to do PETs. They used transphysial screws in the femur and on the tibia. 6 months later, his discrepancy was 2.4 centimeters. Okay, so I think having said that, can I go to the literature review and we can discuss further after if you want?
Yeah, please.
Okay, so the longest series that has been done in epiphysiodesis that has been reported is the series by Makarov of 863 patients. And most of them, they were open epiphysiodesis, and up to 7% had complications. The most common complications were not related to the growth plate, but they had 3.3% of the patients who had residual angular deformity. They had the new angular deformity. And in 3 cases, 0.4%, they had persistent growth despite epiphyseal removal. So the patients with complications were the ones that had bigger leg-leg discrepancy, the ones that were younger, and the ones that had an origin of congenital. And overcorrection was extremely rare, only 0.7% of the patients. So in a review of the group of Bowen, they show a report of 97 patients doing percutaneous epiphysiodesis. They recommended to take away a third of the physis on every periphery. And in a review of a group of 97 with trauma, congenital, and idiopathic, they found that the final leg-leg discrepancy was 1.3 when the mean predicted was 5.2. They had very few complications, 6%. And again, 3% of the cases failed to close despite the percutaneous epiphysiodesis. So the group of arrows show that tension band plating is effective in controlling growth in a porcine model. And there have been a number of studies that they have compared percutaneous epiphysiodesis versus tension band plating. And they showed that one of the studies, the Borba study, showed that on the temporary system using 10-band plating, an inhibition of only 26% was observed on the at 12 months versus a 36% on the definitive. And when you look at the 24 months, still was a difference between temporary and definitive in favor of definitive being slightly more effective in controlling leg discrepancy. In another series of Bayern, they found that over 72 cases, they compared cases with temporary versus percutaneous definitive epiphysiodesis. And they found that the temporary epiphysiodesis had a lower rate of correction. And especially in 4 patients, they hardly achieved any kind of correction. They describe one general recurvatum. And contrary to other series, they show that the tibia percentage of improvement was identical with percutaneous epiphysiodesis and with tension band plating. And also they noticed that in this group of 72 patients, of the 24 patients with tension band plating, 4 required an additional percutaneous epiphysiodesis because of not achieving growth arrest with the tension band plating. It's another study where compare pets with tension band plating. And it's interesting that the inhibition achieved, it's highly variable. And in tension band plating goes to 23% at 6 months, and in pets in 67%. And at the level of the tibia, it's really where the inhibition is less, with only 16% at 6 months and 29% at 18 months. Also is in a study of the group of Norway, where they tried to do a prospective study on epiphysiodesis with 8 plates in the tibia, and they abandoned it because at 12 months, they didn't manage to get any inhibition of growth. But probably to me, the most interesting paper to read is the one of Pendleton, who shows the control of leg discrepancy using band plating. And he reports that they see always a delay in acting. And if you're going to use tension band plating, they suggest that you should do it an earlier than you would have planned for an open epiphysiodesis, because it gives you a better chance of correction. And also they found that in the tibia, it's not very reliable, the growth inhibition that you get. However, if you're going to use growth inhibition, I very much recommend to read the paper of Peter that is here with us on the role of guided growth and related lengthening, explaining the importance of starting early and using a system of serial inhibition of growth and a maximal of 2 years and reassume at 6 months. And for angular deformities, the correction of mechanical axis above neutral. If we look at PETS by itself, it's not all incredibly effective either. I mean, PETS has an efficacy of 35% at 6 months and 66% at maturity. And for the tibia, it's a bit better at the initial 6 months, but the same at maturity. And an important thing, it's up to 20% of the cases finish with an angular deformity. So in summary, I would say that if you're going to use tension band plating, the advice would be to start early rather than late. And probably it's not the ideal system when you are short in time. It's important to keep in mind that at least for what we see in the literature, most systems TBP, PET, and even percutaneous epiphysiodesis have some delay in acting. So you cannot count from the day one. That the tibia is most unreliable in growth inhibition, but also the femur can sometimes be tricky. And the comparison of methods, it's at least controversial and it's difficult to believe. If you use any device, don't leave it for longer than 2 years. And remember that even definitive epiphysiodesis takes time to act. And I certainly would recommend to read the letter of Peter Stevens about the invalid comparison between methods of epiphysiodesis in reply to the work of Gametry, because I think there's a number of important explanations and helps to understand what we're doing and how we should do it. And that's all about leg length discrepancy. So I don't know how well we're going in time, or it's, you tell me, Darren.
Yes, we can take one point because still we have 10 minutes for the discussion, so we can take one point.
Okay, so let me move to one of the questions requested, and I will show you another case. Okay, that's an angular deformity. It's a child with multiple enchondromatosis, age 8 plus 9, that consults because of limb deformity. And what we did, we treated initially with epiphysiodesis on the right leg, on the medial side of the femur, and on the tibia. And at 10 plus 3, 1 year post-epiphysiodesis, he has a very good correction of his mechanical axis, and there is some valgus deformity of the left leg. And now, ready for opinions. Or maybe,
No,
Darren, should I follow the case and then we discuss?
Okay, fine, we can do that also. So that will save some time. Yeah, please.
Okay. So what we did is we removed the metaphyseal screw. We tried to mobilize a bit the screw, and we planned for epiphysiodesis on the left leg. The removal of the screw was done as an outpatient case. So, and we decided to give a few months to go for the other leg. When he came back 6 months later, we found this situation. It was a varus deformity on the right leg that we already corrected, and on the right leg that we already corrected, and it was a varus deformity, a valgus deformity on the left leg. So we were concerned that it could be a growth arrest, and we went to explore and to look for the plates. And what we found was that new exostosis has grown over the 8 plates and has produced the 8 plate to keep acting while the 8 plate was in place, in fact, acting as if the 8 plate was working at the moment. So what we did is we did an epiphysiodesis on the contralateral side to correct the femur, and we did the correction of the valgus on the right side. So that's a bit the sleeping plates and what we talked before of the complications of the sleeping plates. And I think it's, if we review to the literature, well, besides the advice of Peter about how long we should use it, there is some article that has called up about the importance of elevating the plate when you leave a sleeping plate and just fill the gap with wax just to avoid the growth of a spike inside the plate. And it's also a work coming from Israel were compare two groups, the ones that they removed the plate and the ones that they didn't remove the plate, they only took off the metaphyseal screw. They found that the recurrent rate of the deformity was around 18%, around 20% for both groups. And in the group that they kept the plate, they found that 9 of the patients, the hole that they left in the metaphyseal area was not suitable. I think it's quite normal because you were expecting some growth. That 2 patients had a supposed growth arrest that I query if it was really an arrest or an overcorrection. And 41 patients required a second surgery for plate removal. So to me, it's one of the things of concern that you're just doing extra 41 surgeries for saving 12 surgeries. So I think you have to be very selective when you use your sleeping plate. It shouldn't be used universally. It's only indicated for these cases that has a high chance of relapse or for growth modulation, and that you have to follow the technical issues. And obviously, after our experience, I would never recommend it in multiple enchondromatosis. So please, if you want to make your comments about that.
Okay, so we will discuss 2 questions in this point. The first is at what point we should consider for removing of a plate or a screw. That's the first question. And should we remove everything or at least 1 screw? So which is the option, the sleeping or the sleeper plate concept? The Peter has published a paper on that. So we would like to understand different experts' view. So let's start with Berne. What do you think? When do you remove the implant in the case of angular deformity? When the mechanical axis passes through the center of joint, or there is some degree of overcorrection?
Yes, well, looking at what Ignacio has shown us, I haven't any experience. I do not have any experience concerning this overgrowth, but it's very, it's very good to see, and thank you for that, because this has not been my concern previously, but I think this is a serious complication, you could say. And in relation to HME as these kids, I'm using 8 plates and they are very successful. But I do really always, I would say, use long screws, because the bone is to me a little bit different. It's more soft, and it takes longer time. It takes several months before it's working actually on my patients, and I use it preferably only in the distal femur, because I have also this experience with this tibia, and tibia is not my friend. It's not working for me in relation to HME. So I'm only going in the distal part of femur and expecting a longer time before it works. And then I take all the material out. I don't let anything stay in place. And now I can see that was a good idea, but I haven't do any academic thinking about that. So in relation to these exostosis kits, it's very helpful for me to use the 8 plates. But another thing is that I would like to ask the panel they have a lot of pain, and I don't know why. And they maybe they are more sensible to pain, but they are complaining more than other kids. So I would like to hear your opinion in relation to that. But to me, sleeping plates is not useful in HME.
Okay. Yes, Sarul, what is your opinion about this?
So I have used, in a couple of patients I have left them, and typically that's in case of dysplasias, multiple ectophyseal dysplasias or spondyloepiphyseal dysplasias, where you expect that the deformity would come back. But in 2 patients where we left it, those patients did have some pain, and after 2 months we had to remove the sleeper plates. So after that, whenever there is a question of implant removal, I have removed the entire set of implants. Now, I had a personal communication with Dr. Peter Steven about one of the patients, and he said that, if you are doing 8 plate early for genu valgum, for example, for a 9 or a 10-year-old child, and you get correction by 10 or 11 years. And then there is a doubt that the deformity would come back. And he did suggest that in some of those patients where you do an early correction of genu valgum, will it be worth retaining the plate and telling the parents that if the deformity recurs, you put a single screw and have the plate work again. And if deformity doesn't come back at maturity, you remove the plate. So that was, one idea he did suggest, and I've done it in a couple of patients where we've had to do genu valgum correction very early on. But for dysplasias, now I remove the plates and reinsert them because they grow up and the size of the plate also changes. After 2 years, you will have to use a different size of a plate, and I don't retain those plates.
Okay. Yes, Peter, what is your opinion about that?
So I use intermittent guided growth across the board in all conditions. I agree that HME is kind of a unique problem, but even idiopathic, if a patient with any diagnosis has more than a year to grow, I offer the family taking out the metaphyseal screw. And of course, nowadays they say, send me a picture once a month, especially if their knees and ankles aren't touching at the same time. I definitely need a picture, but I try to have them send one every month so that I can share in the decision-making. And on occasion, and you'll prevent serious overcorrection by doing that, no matter what country you're in. It's generally easily remedied. I agree with what was done in this case to take out the medial plate, take out any osteochondroma that's formed over it, and tether the opposite side. And I've yet to do an osteotomy in so doing. So again, I engage the parents, I give them the option. They're very kind of leery of starting over and putting in a whole new plate. One reason I start correction young, sometimes very young, especially for valgus, is this is a condylar hypoplasia of the entire lateral condyle. So they get a shallow sulcus, patellar femoral instability is a risk. Now, if they're playing sports, ACL injury is a risk. So to me, it's better to do serial repeated correction to mitigate against those potential problems and against the circumduction gait. And I don't put
Manoj, a quick.
I don't worry about if the plate and the epiphyseal screw are in good position. I'll take out the metaphyseal screw. If the epiphyseal screw is close to the physis, I'll take the whole thing out.
Yes, Manoj, if you have anything different to say.
I don't have much experience with using sleeper plates or intermittent growth modulation. And having seen this case, I would be like even more cautious about it. I can see the rationale behind in dysplasias, but as you're probably aware, we have problems about in idiopathic ones actually coming quite late. We don't have them coming early, and so I don't have much to add on sleeper plates. I don't have much personal experience on that.
Okay. Right. Fine. I think that there are still a lot of points to be discussed, but because of lack of time, what I would request all the experts to come again to this webinar, and we will do the part 2 of this webinar, because we realize that there are a lot of controversies which requires discussion. So now I hand over to our secretary Sandeep for vote of thanks. Over to you, Sandeep.
Thank you, Dhiren bhai. So at the outset, let me first thank Ignacio and Dr. Yadne and Dr. Peter Stevens for agreeing to our request for this beautiful interactive webinar on growth modulation. And as we all saw, ultimately nature is king. In spite of all our efforts to try to control it, ultimately growth can fool you and behave exactly the way it wants. Probably there's a lot of genetic element, there's a lot of hormonal thing that is also involved, which is beyond our control. There are complications with growth modulation, which have been very well highlighted and brought out. In fact, in our country, as Taral and Manoj, like they contributed and pointed out, that it's the matter of them coming late. And even after we use growth modulation, sometimes we get patients lost to follow-up. They turn up after 4 years with a deformity in the opposite direction. In fact, I've had 6 patients which we are writing about who came with severe genu valgum. We put the growth modulation 8 plates. They disappeared for 4 years and came with severe genu varum. And then we had to remove the plates from one side, put them on the other side, and now they have corrected again. They just forgot that they are supposed to come back on time. So that these are the unique problems that we face back home. And as Dhirenbhai has rightly pointed out, many more points need to be discussed. So again, we should have a part 2 and discuss a few of the nitty-gritties. And we saw a lot of variation: short screw, 2 plates, quad plates, long screws, PETs. But still, either everything works or sometimes nothing works. So the jury is still out there and we don't know the real and the whole truth. So with those final thank you words, I think it's good night from here, and we hope to see you again soon.
Yeah, Ashok, can you stop recording?